So without further ado, welcome once again. Mark Denning here. So glad you're here and with us. And I'm going to turn this over to Dr. Lyle Ignace. His idea was to host these Native Strong meetings. And this is a native to native conversation. And we want your input. So again, Dr. Ignace, your presentation and words for our week.
Sure. Thank you, Mark. Thank you, Jeremiah. Thank you for tuning in to Native Strong. This is week 10, and we've certainly had an interesting week throughout the country, that's for sure. So again, I want to thank you for tuning in. And just as Mark said, this is a native to native conversation, and a venue that is important. I believe, we all believe, to be important to hear voices from natives about this pandemic and how we can help each other not only get through this, but also gives me an opportunity to share what I'm seeing in Indian country. So let's get right into the numbers here. So from a worldwide perspective, over 13 million cases worldwide, 12.6% increase from the week prior. That's been pretty steady worldwide. In terms of recovery, almost 7.4 million. That's 15% from the week prior, slightly down. In terms of case fatalities, 577,000. This is relatively flat, has not significantly changed from the week prior. Here in the United States, we're over 3.4 million cases, 13.2% increase from the week prior. Last week, obviously, was very significant. We saw increases in multiple states, California, Arizona, Texas, Florida, pretty significant increases in hotspots here. We've now tested over 42 million tests that have been performed. In terms of recovery, over 1 million individuals. It's a 38.2% increase from the week prior. So as much as there are positives, there are people that are recovering. 131,000 fatalities, 3.86, that's relatively the same, has not dramatically changed from the week prior. Here in Wisconsin, 38,727, 16.8% increase. This is certainly significant for us here as the numbers continue to go up. In terms of recovered, almost 30,000 individuals have been at least known or documented to be recovered, 13.8%. And so we see a slight divergence here where we were used to seeing fewer cases and more recoveries. That is now flipped, and we're now seeing more cases and fewer recoveries. So there's going to be a change, a shift in the status of active or recovery of cases. 827 deaths, 2.4%. Compared to last week, not much of a change, but if you look at trends over the last several weeks, this is actually going down. So that's important to keep in mind. Despite more cases, we're seeing fewer fatalities. Next slide. So just a reminder, as we go through Indian country, 573 federally recognized tribes. There's an estimated 5.2 million self-identified American Indians and Alaska Natives in the country. Half of those utilize the federal tribal urban program system nationwide. There is 573 federally recognized tribes with their respective reservations. We know the vast majority of individuals do not reside on their respective reservations, and nearly 70% of the Native population live off the reservation. So that's important to know. Here in the Bemidji area, that includes Minnesota, Michigan, and Wisconsin, 34 federally recognized tribes with their respective health centers, as well as 4 urban programs. And so that's Minneapolis, Milwaukee, Detroit, and I include Chicago in that area as a state, as part of the Bemidji area. So let's get into the numbers from the week prior. So this is as of July 14th, the most recent numbers. As you go down, you can see there has changed. There have been changes that have been ongoing. The ones that pop out the most are Albuquerque, over 1,000, Great Plains, Nashville. Obviously, we know about the Navajo area, Oklahoma City, Phoenix, and Portland as rounding out over 1,000 cases. And so when we start looking at the numbers a little closely, we see, a number is a number. It doesn't mean anything unless you put it in context. And so that's what the Native Strong has been about, is trying to put this in context in terms of numbers. And I try to look at the trends and present these trends to you. So as we go through the weekly numbers here, we can see that there have been dramatic changes from the week prior. Everything that you see in that column, July 15th, so these are number changes from the week prior. So everything in red is significant because these are obviously changes that have occurred in each respective area. So essentially every area has shown a dramatic increase from what their baseline numbers have been showing. So Alaska, Albuquerque, even here in the Bemidji area, Billings area, we see Navajo, almost 600 cases, which is significant. Oklahoma City, 665, in the Phoenix area, 829. So, these are areas that have been in the news, they've been in the headlines, and obviously big concerns. But when you get down to the bottom, you see a number, 3,052. This is the highest number of cases that I have seen since we began this town hall. So 3,000 cases. The closest, what we thought even a couple of weeks ago was fairly high. That was only 2,374. We thought that was high. Well, it's even higher now. And so when you start looking at what's going on in every area, we're all testing. We are all, contact tracing. We're all trying to mitigate and social distance and assure ourselves that we are trying to minimize transmission. But just like everyone else in the country, we're seeing these numbers, and they're dramatically increasing in every corner of Indian country. So you can just look as the weeks have gone by. The areas highlighted in yellow certainly signify the number that has dramatically increased. And so as we go further to the right, we start seeing what the percent change has been from the week prior. At the bottom, the percent change average is a little over 13%. And as you go through every area, you can see the significant change that has occurred. So Alaska, nearly 65% change from the week prior. Billings, 31%. Oklahoma City, 36%. Tucson, 31%. So these are pretty significant changes, pretty dramatic changes. And I see this consistently across the board. It's hard to see numbers from day to day and you can make inferences, but when you start grouping patterns and groups, you can see a much different trend rather than from a day to day. So on the far right-hand side, we see the trend. Every area is on an upward trajectory, except for California and the Great Plains. They've increased their numbers, but they've plateaued and they've just stuck there. They haven't significantly changed. So the numbers there are flattening. Area such as Portland, so this in Portland area includes Oregon, Washington, and Idaho. Their numbers, they've gone up and they've stayed there and they've just maintained that level of cases on a weekly basis. So, but everywhere else in Indian country, the numbers are up. And this past week has been the worst. This has been the worst week in terms of coronavirus for Indian country. So next slide. One of the things that I introduced last week was Indian Health Service and the numbers that they generate. So if you were to receive a test and a result from one of the federal tribal urban programs, your number gets registered as either being positive or negative. And so what I've been trying to identify here is I've used Bemidji, Great Plains, and the Billings area, and what IHS has registered as a positive number. But that's part of the story. I mentioned that 70% of the Native population reside off of the reservation, and so they utilize health systems of wherever they may reside, they use their health system. So that's not a federal tribal urban program, but they're still Native, and their cases do matter when we start adding things up. So here in Wisconsin, as we go down, you see 361, Minnesota 350, Michigan 292, Illinois 228. So these are from their respective health department websites. And so when you tally this all up, we see a number of 1,231. That's obviously much different than what the number IHS is able to provide. That's mainly because they're using numbers that are coming out of the federal, tribal, and urban programs. I'm looking at statewide, and this accounts for not just the ITU system, but also all other self-identified natives in their respective states. So we see that in Bemidji, in the Great Plains. IHS says there's 1,234. Well, looking through the numbers, South Dakota, so Great Plains includes North Dakota, South Dakota, Nebraska, and Iowa. When we add that up, that's 1,839. North Dakota is, believe it or not, is the only state in the union that does not report racial ethnic demographics. Why that is, I don't know, but you can see even by the state websites, health department websites, their total numbers are much higher than the federal tribal urban program. So if North Dakota's numbers were included, I suspect that we could be looking at maybe close to 22, maybe 2,400 cases of coronavirus in the Great Plains. In Billings, again, Billings area includes Montana and Wyoming. There are 6 federal sites, 2 tribal sites, and 5 urban programs in the Billings area. So IHS 506, but when you look at the state websites, 547. So there is a discrepancy in numbers. So if you were just to rely on IHS, you would actually get a lower number of what actually is going on in the country. And this is pretty consistent from what I'm seeing from what most of the states are reporting on their racial and ethnic demographics. Next slide. So just going around the Bemidji area in terms of state cases, Wisconsin, here in Wisconsin, 38,727. I mentioned 16.8% increase, 5,573 cases. These are new cases, and that's pretty significant for the state of Wisconsin. These are new high mark numbers for Wisconsin. In Michigan, 71,197, 4.8% increase, 1,695 cases. That's, you know, in the very beginning of this pandemic, obviously Michigan was much higher. It's one of those states that was really affected by the virus. Now we're seeing those numbers go down, and they kind of pale in comparison to what we're seeing in Wisconsin. Indiana, just to kind of get a regional perspective, Indiana, 53,370, 7.7% increase, 3,834 cases, and they seem to have plateaued, and hopefully they're trending downwards. Illinois, 156,000, 4.9%. They're on an upswing right now with 7,261 new cases. Minnesota, 43,000. They're on an upswing, 10.5% increase since last week, 4,153 new cases. So again, a mixed bag. Not all states are affected the same right now. You know, Michigan, Indiana, Illinois, you know, they were dealing with high numbers. They've bottomed out, and now they're kind of having this up and down low number for them. So next slide. Let's get into the tribal reservations and some of the trends that I'm seeing. Now, I don't have numbers specific to tribes, as not all tribes are publicly announcing the number of cases. But as a default, I'm utilizing the counties that the tribes reside in as kind of giving a reference point of the activity that's going on. So as I mentioned, Michigan's numbers a bit of on an uptick. And so as we start going through all of the counties, you know, there's modest increases, but they're upswings in relations to the counties. You know, some of these tribes reside in the northern aspects, and populations are not as dense as the major cities. But any increase in numbers can be certainly significant for that county. So that's why I put a U for an upswing. And so you as we go down in terms of counties, double-digit numbers for a fair amount of them, and then like Little River, Ottawa, their numbers are actually flat. So they're not a lot of numbers, but again, consistent numbers across the board. So as I mentioned, 292 cases. That's 15 more than the week prior. Essentially, their percent increase has not changed. So from my perspective, the impact on Native tribes in Michigan has been fairly modest, and most of these cases are mainly in the southern aspect of the state. Majority of the cases are in and around the city of Detroit. Next slide. In Michigan, the 11 tribes in Michigan, as a default, we'll utilize the counties. And so as you go through the counties, you know, Minnesota was on an upswing in terms of counts. And every tribe, you know, some of the, like Red Lake, Leech Lake, Fond du Lac, Shakopee, their county numbers have shown an increase, double-digit increases. And so that's pretty significant, especially in the more northern tribes. White Earth and West Fort, their numbers have remained pretty flat. No significant changes up or down, just consistent numbers on a regular basis. So Minnesota's native numbers, 345, nine new cases from the week prior, really a modest increase, 2.7% from the week prior. So Minnesota the tribes of Minnesota have certainly shown a way to reduce their numbers, and so that is a good sign for Minnesota tribes. Here in Wisconsin, we see the 11 tribes in the respective counties. Majority of the counties have shown an upswing in terms of numbers. Again, double-digit numbers. A couple that have shown numbers that are fairly low, but again, smaller populations dealing with any positive cases can have an impact on the community. So nearly the majority of tribes in the state of Wisconsin have definitely shown upswings in numbers. And at least what has been publicly announced, we know that Ho-Chunk has come out as of yesterday documenting at least 25 cases in Ho-Chunk, Forest County, Potawatomi, in their county, 8. They have 49 cases. They actually have 8 cases of coronavirus. 6 are currently active. And in Oneida, as of earlier this week, it was noted to be 50. And so there are cases, without a doubt, at least on the reservation. And so, but again, we have, individuals that don't reside on the reservation. So when we start looking at overall numbers here in Wisconsin, 361, that is 51 new cases from the week prior. That's a 14%. That is significant for our native population here in Wisconsin. We've never seen 51 new cases in a week. So this is definitely a turn and trend that is going upwards for native tribes here in Wisconsin. So significant for us here. So Illinois, I include Illinois as being a kind of a southern portion. They do have an urban program in Chicago, so it's only proper to acknowledge the numbers that we're seeing in Illinois. They have no federally recognized tribes, but their state website's 228. That's 3 new cases from the week prior. You know, in a state that has a tremendous amount of transmission, community spread of coronavirus. A number of 228, that's still significant. And those are still our brothers and sisters, even though they reside in Illinois. So it's just prudent that we include Illinois in this discussion, because it's important to acknowledge we don't all live we all live in different portions of the country. So we do have family that live in Illinois. Next slide. So bringing this back to Wisconsin, I mentioned the cases here in Wisconsin, 361, 310 last week, 51 new cases, 14% increase. So it just is a very good reminder that the cases, when it comes to other demographics, certainly not as significant or high, but again, we're dealing with a smaller population than everyone else. So any new change can be significant, especially here in Wisconsin. On that bottom row is basically all the numbers that I've been following on a weekly basis. And so the changes have been incremental, but you can just see that it just continues to go up and up and up. And this week has been tremendously impactful on the tribes, natives here in Wisconsin, with its biggest increase since the pandemic started. Next slide. Just to give you some perspective, and we're hearing a lot of this in the news now, are the demographics, age demographics. What are we seeing? Here in Wisconsin, I think our demographics are probably more pronounced than what I'm seeing in other states. But here in Wisconsin, the age group that is the most dominant in terms of new cases is the 20-year-olds, the 20 to 29-year-olds. So I've been giving numbers and profiles of age demographics as the weeks have gone by. And you can see in the upper right-hand corner, starting with June 14th, those demographics, 20, 30, 40-year-olds. You can see the ratios of splits, 19, 18, 16. And as the weeks have gone by, you can just see the change. You can see the change. You can see the numbers change. It just becomes more and more dramatic over the last couple of weeks. In particular, there's even more of a dynamic shift, because if we look at July 15th, so this would be yesterday's numbers, the 20-year-old age group, 25%. So again, another dynamic shift in the number of cases. We see the 30-year-old number actually going down, and we know the 40-year-old age group is going down. So again, what was going on in the beginning? The majority of cases were in our older age group, and now we're seeing that shift going all the way back to now the majority is in the 20-year-olds. What I'm also noticing is age group of 10 to 19, that is starting to increase as well. So there may be another dynamic shift of our younger population coming down with this. Next slide. This is just to give you a sense of what's going on in other states. Minnesota has that dynamic shift of that younger age population. Michigan, not so much, but I suspect as the weeks go by, this will start shifting more and more, and we'll start seeing more and more younger people. Same with Indiana and Illinois. The majority of new cases when this was first going on started out with that older age group, and now it's swinging all the way back. So I expect these to start shifting in the weeks to come. Next slide. So everyone that's been following the news in the last couple of weeks, there's been some pretty dramatic changes in the number of cases, daily cases for us. At first, we had the trend was actually going downward, peaked May 30th, then the 7-day average at that time was 479. Then we started getting numbers, lower numbers, and then we bottomed out June 16th with a 7-day average of 266. Since then, you can just see that upswing, and it just seems like it's not stopping. And I'd say, yeah, you're right, it's not stopping. And so we've been on a pretty horrific streak the past 7 days. We've seen kind of five of the last 7 days of record numbers for the state of Wisconsin. And up until this past weekend, we had a record-setting number of 754 cases. That was a new record. And the next day, 845, that was a new record. And on Sunday, 926, that was a new record. And then we dropped down for Monday, but then we had a new record of 964 on Tuesday. And as of yesterday, the numbers just came out, and now we're talking about 900. So this week has been absolutely terrible for the state of Wisconsin, and this block time in our 7-day average is going to reflect that. So we are now at 796 with today's number. It's going to go over 800, and so we have not reached that plateau. We have not gotten to that peak yet, and so my question will be, what's that going to happen? And I don't know. We're all going to need to see that play out here. Next slide. So as we pull back to Milwaukee, and where our urban program resides, 13,430 new cases, 359 fatalities. So as you look, just kind of browse over this, you see in the middle, all of the yellow circles. Those are basically census tract numbers to identify cases in these census tract areas. There really isn't a whole lot of difference. It's pretty evenly spread throughout the city. Maybe one or two areas, one in particular just north of the highway, where you have close to 30 cases in the past week. So but that would be a hot spot. Everyone else is usually in the teens and nothing more than like 17, 18. And then everyone else is like single digits. So new cases every day, pretty evenly spread out through the city. So just a quick mention, the age group, that second graph, that middle graph on the left-hand side, I follow this on a pretty regular basis. So the 20 to 29, again, we're following Milwaukee is following suit with the state. That age group, that demographic age group is definitely increasing. The other thing that I've noticed as well is the 10 to 19-year-old age group as well is also increasing here in Milwaukee. So that's going to be the new focus, is these younger adolescents becoming more and more part of this discussion. Today's fatality, I had mentioned 359. This is actually there's been one death in Milwaukee in the past week. So it seems pretty hard to believe that, but yeah, there's been one death in the last 7 days here in Milwaukee. So even though we're seeing new cases and they are younger, and the majority of young people vast majority will recover and do fine, on the back end, we're seeing very, very few dramatic changes in the number of fatalities. So again, kind of a mixed bag of good and bad. Next slide. And here, I just want to look at the demographics, racial demographics here in Milwaukee. Obviously, our Latino, Hispanic, and Latino population have the vast majority of cases, and then to the far right here in Milwaukee is we have 50 documented cases. So, so still an ongoing active process and active cases still going on here in Milwaukee. So next slide. I wanted to shift gears and talk about recent developments, and these are really, they're not new. I do presentations on this, and I bring these up to my employee staff on a regular basis. So my staff are familiar because I bring this stuff up to them all the time. But we're talking about mitigation, we're talking about therapeutics and treatments, and you know, I think the discussion in and around vaccines are going to take they're going to take up a lot of headlines in the next couple of weeks. I want to bring this out now so people have a familiarity in what to look for in the next week. So when it comes to this virus, basically one of several things need to occur for this to happen, for it to go away. Either one, the virus burns itself out. It burns itself out, and just like the flu, we have a seasonal aspect to this, where it introduces itself into a community, cases occur, and then burns itself out. That would be a seasonal, like the influenza virus, that would be seasonal. Two would be as if we developed pharmaceutical therapeutics to treat. So just like you would get a bacterial infection, you get an antibiotic. That is a antibiotic that treats the infection and it goes away. We have not found a treatment. We have medications, remdesivir, dexamethasone. You probably heard or read about these in the news. These are medications that help. These are therapeutic. So they're not meant to treat, to get rid of the virus. they're in support of management or the treatment of folks who are severely ill to minimize the uh, um, um, to minimize the severity and allow individuals who have severe infection to mount their appropriate response to get over this virus and to recover. It's not meant to treat, so it's not like I give this to you and you're going to be fine. But that's also this. The third would be talking about vaccines. And so I wanted to bring up what I've noticed, and I presented this about a month ago to my staff, and I told them to watch out for these because the information's coming, and that time is now. So I want to bring this up to this group here. So biotech companies, Moderna. Moderna is a biotech company out of Massachusetts. So they developed their vaccine, and they came out with an announcement that showed 45 out of 45 people showed high levels of antibody formation. Now this is very significant because they're talking about antibody responses higher than even people who've actually been infected having an antibody. So 45, 100% of their profile has shown a dramatic response, and this is a very good phase trial and data information set. So Moderna is definitely on the table. It is definitely going to be talked about. Because of this, they are now moving into their phase 3 human safety trial. So they're looking to gather 30,000 individuals, volunteers, to be part of that Moderna's vaccine phase 3 trial. So that's one. You may have also heard about AstraZeneca. Now, this is interesting because AstraZeneca was really at the forefront. They were the #1 group ahead of every company that was trying to develop a vaccine. So AstraZeneca, they've partnered with the University of Oxford from the United Kingdom and with the United States. So the US with the Department of Health and Human Service actually went into an agreement with a very large investment. This happened about maybe 6 weeks ago. It got little press, but it was a big deal. It was over $1 billion investment by the US HHS to get in with Oxford, University of Oxford, and AstraZeneca. Now, at that time, they had data, they had information. This agreement with the United States was to develop and be able to provide 300 million doses of this vaccine. Well, AstraZeneca just came out with their announcement saying how effective their trials have been and their data in support of their vaccine. This is huge, huge news because AstraZeneca was on the forefront of all of these companies. They are already in phase 3 right now. They are already in phase 3. They are garnishing their 30,000 volunteers. And they announced about 6 weeks ago, if things went as they expected or as they hoped in their development, that they would actually have a vaccine this fall, before Christmas. And that is huge news from AstraZeneca. So as I mentioned, next slide. So, the University of Oxford, AstraZeneca, U.S. partnership in this, they are going to be able to secure now, since 6 weeks ago till now, 400 million doses. And so they feel they could develop 2 billion. They think they can develop 2 billion doses and be able to deliver them as soon as September. Now, we'll see. We'll wait and see. The last biotech company, is Pfizer. Pfizer, their CEO just came out in an interview on July 7th. They have already gotten their data. They've presented it to the FDA. They're waiting approval, but at the same time, they're not waiting for the FDA. They're already mass producing their vaccine. They are so confident in their vaccine phase trials to this point that they feel they can mass produce their vaccine in anticipation that they feel FDA is going to approve. So they're working in parallel. This never happens in developing a vaccine. So all of this effort in developing a vaccine right now is under this program called Operation Warp Speed. In virology and vaccine development world, this is what has occurred in the last 6 months is absolutely warp speed. Typically, a vaccine takes 5 to 6 years. It takes 5 to 6 years to develop a vaccine, only because it works in a linear sequential effort. That means we do one, we get approval to go to step 2, then we get approval to go to step 3. And you can imagine it takes a long time. It takes a very long time to get to a point where a vaccine would be able to show not only safety but also efficacy. The fact that things are being in parallel, things, the FDA, NIH, CDC, they're all working together. Public, private investments that are going on. This has never happened in our world history, develop a vaccine this quickly and for the approvals to move so dramatically. And we could very well see a vaccine before Christmas. And if that occurs, it's going to be a game changer for everyone, without a doubt. So I wanted to bring that up. I wanted to discuss that because if we don't hear much in terms of this week, we're definitely going to be hearing things next week. And so I wanted to bring that to your attention and at least assure you that, we're not talking about, late next year vaccine. We're talking in the next 3 months, 3 to 4 months. And so that is a game changer. So I just wanted to quickly go through reminders here. As far as risk, I just want to re-emphasize who are individuals that are at risk. We know 65 and older, nursing homes, long-term care facility, people with chronic, high-risk chronic care conditions are definitely at risk. So that definitely involves our parents, aunts and uncles, grandparents who may reside in a nursing home or assisted living. So these are a very susceptible population. Next slide. In terms of our activities here, supporting the Native community of the greater Milwaukee area, we provide safer at home kits. These are personal hygiene and cleaning supplies. So if there is a need for these, just call 414-316-5051. Ask for Alicia Terry, and we'll get you set up that way. And just to highlight some of our other programs, we have our Circles of Strength program supporting domestic violence, sexual assault, and individuals who may be impacted by this. We also have our youth empowerment program supporting our Native youth during this time, during the summer. We're also offering prevention and weekly discussions on prediabetes, high cholesterol, and high blood pressure. So, and then obviously testing. We have the ability to test. We have the confirmation test, the antigen test. We have the Abbott ID Now analyzer that allows you to know if someone does have the coronavirus within 5 minutes. We have that testing capability here at our site. Fevers, chills, cough, short of breath, headache, extreme muscle fatigue, body aches, nausea, vomiting, diarrhea, loss of smell, loss of taste. These are the most prominent signs of COVID, of being infected with COVID. And so if there are individuals that suspect or feel they may be having either one or multiple combinations of these symptoms, please don't hesitate to call. Someone will evaluate and assess your need for testing, and we'll set up a date and time to do that. Next slide. And just reminders, the public health messaging to wash your hands, social distancing, and wear a mask. And so these are the three pillars, the cornerstones of how to reduce your risk, minimize transmission, and protect yourself and your family. With that, I'm going to turn this over to Mark and Jeremiah, and if we have questions, I'd be more than happy to address these.
Dr. Ignace, a couple things occur as you're looking at this. There's been a lot of kind of conversation across social media about vaccines. Yep. And you have anti-vaxxers, I believe is the term, on one side, and folks who are largely silent on the other, because certainly they're not sure what exactly to say of vaccine that they don't even know exists. Well, now we know that there's 3 different iterations of something that's out there. If you could just kind of break it down for moms and dads and families and people who watch what we have going on here, what exactly is a vaccine and how does it work?
Sure. So a vaccine is a vaccine. So, you know, we're talking about polio, we're talking about measles, mumps, and rubella. We're talking about a bacterial vaccine against pneumovax. We hear about pneumovax that prevent the bacteria that cause pneumonia. We have influenza vaccines. So, you know, we have vaccines to prevent in all of these diseases I mentioned. They're very contagious. So polio, absolutely contagious. So vaccine development was intended to develop a community, and this will be another term you're going to be hearing soon with the vaccine discussions, is herd immunity. Herd immunity is when you want a certain population to have the immunity, either by having the disease or either through vaccine to develop an antibody response. And if you have a certain rate of a population that has that immunity, that infection actually it burns itself out and fades and goes away, or minimizes its chance to infiltrate into a community or even, you know, state, or city, or a country. So polio vaccine, measles, mumps, rubella vaccine. We don't hear about these diseases anymore is because we've developed a vaccine. The vaccine is developed out of the proteins based on the makeup, the genetic makeup of the virus itself. So being able to engineer a way to identify the chain of the virus, to identify the chain that doesn't modify. You want to develop a vaccine that recognizes this, and your body is able to develop an antibody response. And that's a good thing. That's what we want. That's what we want to see. And being able to develop a vaccine that creates a body process to create antibodies is a good thing. We want that. We want our bodies to develop an antibody response to infectious problems. So polio is essentially non-existent in the world. There are cases that show up here and there, but again, we've created a vaccine. We've gotten to that point of this herd immunity where we don't see it. It's not that polio doesn't exist. It still exists out there. It's just people aren't getting infected with it because they have the antibodies to mount a response against it. So it's not like the polio virus went away. It's still here. It's just that we don't see the infections because we have the immunity. So, so when we talk about this particular vaccine, and it's important to realize that things are moving pretty quick. And I know there's a little trepidation about whether or not they should trust this vaccine or any vaccine that comes out in such short order. I would say what has occurred now in the year 2020 versus what used to be the model and technique engineering of vaccines, let's say even 30 years ago, is vastly different. We have computers, we have robotics, we have such precision. We're able to genetically replicate every DNA portion, an RNA portion of a virus or the human body. We have such the vast knowledge and experience and expertise to now understand everything about the human DNA and RNA, and there's new stuff that comes out all the time. But in regards to this vaccine, or at least this worldwide approach to the vaccine, it's important to realize that all the research and development up to this point is such a great thing, because we can do it almost overnight versus what would take a couple of years to formalize. Now we can do it. I know there's a question about whether or not the rate of producing such vaccines, is it safe or not? And the answer is yes, it is safe. Yes, it is being produced at a very fast fast way. But I would say that when in terms of the phase trials, phase 1, phase 2, phase 3 trials, those portions don't change. What I mean by that is to develop, it's one thing to develop the vaccine, but to test it, you need that particular group of individuals to be tested. I had mentioned Moderna, I had mentioned AstraZeneca. They went through their phase trials and the designated number of individuals that have to be part of that trial and then show what their data is. That portion of testing doesn't change. That's the same type of process from either this vaccine or any other vaccine or any other pharmaceutical that's being developed. It is the same process. It's just the approval process and the distribution and manufacturing that go behind the scene that is going so fast. So whatever safety profile and efficacy that comes out, the numbers will be the numbers. And so if they come out and say, you know, our data supports X, Y, and Z, or it is safe, or in terms of side effects, maybe we have you know, one vaccine come out with a safety profile of maybe having a headache, or may develop nausea, or may have body aches. If it's a small number, and it could have a vast majority of side effects. All vaccines have some side effects. But if the safety profile is very low and it has a good response, I feel the vaccine would be safe to get. So I think the last portion of vaccines before they go out into the general public is this phase 3. This is where they test on a large scale. So 30,000 people need to be volunteering for this. So this is where you start getting really into specifics. You need to have an equal amount of men, women, of all age groups, because we're talking about vaccines from adult to infants here. So we're talking about male, female, age. We're also talking racial and ethnic distributions as well. We're also talking about along lines of even underlying chronic medical conditions. So all of these categories have to be filled with volunteers of all race, all ethnicity, all genders, age groups, and that's how they're able to develop these safety profiles based on this larger gathering of volunteers. And so so high risk, whether we're talking about people over the age of 65 or people with chronic hearing condition, they are part of this test profile. They're part of that phase 3 trial. So I hope that helps kind of answer that question that was brought up.
So as we're looking at this, just kind of my math, it looks like we got about 90,000 people out there about to be tested. Does that mean that these are 90,000 Americans and this vaccine is proprietary to America? We see that, unfortunately, medicine and its applications has been politicized. And, it seems like we're going our own way. So my question, kind of building off of what you said, is, are these three companies in conversation with each other? Are they developing things together, kind of pulling together to find the right thing to do? Or are they in isolation and they're doing it in other countries with folks that may have other diets or habits? Or, we may not have that level of detail, but it is an interesting thing. Private business is meeting here for public medicine.
Yep.
And
so,
you got any insights on that?
Yeah. So right now there are over 170 biotech companies throughout the world that are trying to develop a vaccine to the coronavirus. 170. So that really covers the entire world. Each has to go through its phases. There's phase 1, 2, 3 trials. Only 18 have actually gotten to that point of the of phase 2 trials. But there's the companies I just mentioned. These are the ones that are on the forefront of actually being in that phase 3, who have the promise, hopeful promise that they are going to be able to generate a vaccine in short order. So, every phase trial that has occurred or will be occurring, they need to do that phase 3, 30,000. So we're talking about 170 companies. So if they're able to get to that point of phase 3, they're all going to need to go through these phase 3, 3,000 volunteers and their safety and efficacy profile. So they're all going to need to do it. I highlighted the ones that are on the forefront. So in terms of distribution worldwide, so we're talking about, companies, I had mentioned Pfizer. They're looking at being able to generate 100 million right off the bat, and then multiple 100 millions after into the new year. I also mentioned about AstraZeneca. AstraZeneca, they're going to have the capability of being able to develop 2 billion cases now, 2 billion doses. When we start talking about what's the world population, we're talking about 8 billion, nearly almost 8 billion people on the planet. With AstraZeneca being able to generate 2 billion doses, that's 25% of the world. That's pretty significant. And so all of these companies that are going to come out with their version of a vaccine with their safety profile and their efficacy, it's going to be available on a large scale. Now, I introduced this concept of herd immunity. And it's important to realize that herd immunity doesn't mean you have to have 100% of your population immune to it for the virus to die out. No. Herd immunity is you need to get to that tipping point of the population that you're looking at that will render the virus ineffective. And this goes back to, it's going to get a little technical. This gets back to its contagiousness. How contagious is the coronavirus? How contagious is the influenza virus? We know the polio was terribly contagious. But the coronavirus, yes, it is, but not to the extent of what polio was, or even what measles or mumps or rubella were. So it is, bottom line is, when we talk about herd immunity, we're talking about anywhere from 40 to about 60%, depends on what scientist you want to listen to. Anywhere from 40 to 60% of a community or population needs to have an immunity for the virus to be ineffective. So for us to develop even 2 billion doses, given what we already have now and the dosing that could be available, this could very well be a very strong effort to develop immunity in the world to make the virus ineffective. So I know I throw a lot of terms at you right there, but that's what we're looking at, is that tipping point to render this virus ineffective.
A couple of questions, and then we have a third one I'm going to put on deck. That'll be the third question we get to before. So please be patient for those writing in their questions. Two follow-ups on what we're talking about. One of those is, there's a lot of, when it comes to medicine and how they're kind of dealt with in the American population, at least, we know that sometimes a drug will come out and then competitors and generics will follow. Given kind of this race to find the safer vaccine, I would say, let's say they all turn out and they're working. Does that mean that in the United States, of the three competitors, we could possibly have 3 different vaccines on the market, and you as a physician are going to have to choose one for your patients? Or are you going to have people approaching you to sell one of their competitive you see what I'm saying?
Yeah.
I mean, it seems like even this, in the rush, there's still competition that's out there. And how does one know as a layperson, hey, this is one of the 3 that may work better for me? And I'm going to work in that question here, so please consider this, is, are there blood types that are more susceptible to COVID-19? You know, it's just kind of folding that question in this one, because maybe one works better in one case for one group of people, the competitor works best in the case for other people. I mean, what exactly goes into this? Or does the U.S. just pick one winner like a military contract?
Well, right now, the Department of Health and Human Service went into a pretty significant investment in AstraZeneca in partnership with the University of Oxford in the United Kingdom. Both made large investments to assure that the United States would have a portion to have vaccines available. Just like with Moderna and Pfizer. So, you know, the FDA, there are certain thresholds in terms of vaccines effectiveness and whether or not you would allow, let's say, company X had a vaccine that just worked 25% efficacy versus company B, whose vaccine was 80% effective. We're not going to be distributing 25% company A when you know company B is so much better. That's not going to happen. You know, so I know it's their own biotech and their own entities with proprietary information, but it really will depend on how what the efficacy of the vaccine will be, and then its distribution to the world, to the countries, to states, and to the cities, and so forth. So, but again, these companies, it would be unethical to drop a vaccine that is only 10% effective versus another company who's 90% effective. It doesn't make sense to distribute the one that's really doesn't work well. So you go with what works, and that may mean one company distributes maybe more. Maybe one company is 70%, the other one is 72, 75%. I mean, they're both pretty effective, kind of splitting hairs a little bit in terms of which one is better than the other. But when you're talking 70% effectiveness, that is still a good thing. That is still good. So that's the first part. The second part was you talked about blood type.
Yeah.
So when we talk about blood type, I know there was a study that came out of Europe that talked about blood types weren't necessarily meaning that you weren't going to get the infection or the virus. I mean, everyone is susceptible to the virus. What they were finding was certain blood types and the body's response to the virus in terms of severity. And so what they found was people with type A blood had a more severe response. Their illnesses were dramatically more severe versus someone who is type O. So there are 4 different blood types: type A, B, AB, and O. So people with type A showed that they had the more severe illness related to this. People with type O blood, which is more the universal blood, had a less severe reaction or infection to the virus. So now I think it's kind of early to say blood type whatever and what's going to happen to you, because that's just one variable to this. We're still talking about underlying chronic care condition. We're talking about age. We're talking about diabetes, kidney problems, liver problems, cancer, all of these other factors, variables that can certainly change one person's response, even though they may be type O, but they have all these medical problems that would render them, high risk and may have a severe illness as it relates. So time will tell whether or not the type of blood that one has would make a significant difference. So again, this was Europe. It was early on. Believe me, we're going to be studying this every day from here and twice on Sunday to get the definitive type of answer you're looking for.
So looking at blood types, just to be aware, as people are kind of thinking about this when they go in and talk with their physician about COVID-19, maybe it's affecting them personally. Perhaps knowing, kind of having a short discussion on blood type might be helpful. I would imagine. It's a native to native discussion, and I know there's all kinds of blood types out there, but is there a blood type that's more common to Native Americans than others?
Yeah, that's a good question. I really don't know the answer to that one, and I would just be making an assumption here that type O would be the blood type, the universal blood type, and that's universal across all races and ethnicity. So that has never changed amongst races or ethnicities.
So I'm going to get back to the vaccine conversation on a couple points. One dealing with going back to school and schools and children. But the first one, I think it's going to be really important, and hopefully we do get a great result from 1 or 3. How awesome if it would be all 3 and triple the response. But just quite shortly, when we're looking at when the vaccine does come out, whoever gets it, who gets the vaccine first? We're going to have people lining up to say how dangerous it was. There are going to be conspiracy theories. There's going to be things floating around the net. There's going to be fear mongering. But there's also on the other side going to be a line to say, I deserve it. I should be first in line. And not a lot of people are going to be saying that out loud. But there is always a kind of a protocol, a list of who gets what and when.
Mhm.
And so we don't get kind of caught into these discussions of, wondering. Yeah, I wonder if you could look at that question and say, from your experience, when a vaccine is going to come out like this, who gets it first?
Yeah, so I'm sure this is going to be and believe me, this is going to be a discussion that's going to be coming. But I think I think from a public health approach, I think the priority goes to who is at high risk, who is at high risk and susceptible for a poor outcome as a result of the infection. Well, we just went through that list of high risk individuals. So that would be people over 65, nursing home, long-term facility, chronic care conditions, lung patients, heart patients, diabetes, kidney problems, liver problems, cancer patients, individuals with autoimmune diseases, poorly controlled, medical conditions. That's your high risk group. That is your high risk group. And so when we start talking about who else, we're also probably going to be talking about healthcare essential frontline workers. We're talking about priority. So we're talking about a good portion of the population. If we start looking at, if you're looking at demographics of age and rates in the United States, we know the vast majority of the population is in that 30, 40, 50 group, and then 60 less, the numbers actually go down and down and down. So what would probably be the best approach for talking about how do we get to that herd immunity and being very strategic in terms of high risk and high priority groups? You could hit a good portion of the country of 65 and older, frontline healthcare workers in terms of immunity. And I think once you get past that strategic effort, you start moving up that herd immunity tipping point to where, what's the next group? What is the next group? Because the flip side of that is, well, we know kids K through 12, they may get it, but at best they have, or at worst, they have mild symptoms and they recover like in 2 days. And then the next group is the 20-year-olds, where we know there's a vast majority of new cases that are coming out of the 20-year-olds, like the biggest portion of cases right now. Well, they get it for 3 or 4 days, mild, they recover, and they're off to the races doing whatever they want. So we have kind of this dual thing that's occurring, one more naturally, one artificially with the vaccine. So you could get to that herd immunity, young people getting infected, and then the vaccine high risk, high priority groups, and get to that herd immunity point probably pretty quick.
And if as your follow up to this is kind of we've been watching the United States Supreme Court kind of enter and wade into the area of healthcare, who gets what and why, and using religious exceptions. Is there any discussion in the medical community is when it comes to a vaccine, maybe there's anti-vaxxers out there. Mm-hmm. I believe that the United States government can mandate that young people do get vaccinated, but if a parent pulls their child out of school and says, I want to send my young person to maybe a school that's an anti-vaxxer school,
Mm-hmm.
or it doesn't comply with religious beliefs.
Mm-hmm.
And they say, hey, we're going to hit herd immunity anyway. I don't want to do this. Kind of just as a doctor, what's your impression of that? Is that something that you're afraid of, that you're watching carefully? Is there discussions or insights that folks can use? Because I can see lots of people applying for jobs, and if something goes wrong down the line, religious exceptions come up as far as healthcare.
Mm-hmm.
So I think that can be a slippery slope in a lot of ways. And what kind of discussions are you hearing out there, or insights you might share with us about these recent decisions?
So, as far as insights when it comes to vaccine, it, we've fallen in. We know that school age kids, we go through these well checks with our kids when they grow, when they're babies to teenagers, that they have these series of vaccinations, their immunizations that they got. Well, the reason why that's so important, and I'm kind of I'll argue for vaccines. All right. Measles, mumps, polio, rubella, pertussis, smallpox, chickenpox. These vaccines are created and developed to prevent these diseases from occurring. Because the flip side would be, if we didn't do the vaccines, or we didn't mandate, I shouldn't say mandate, or require these vaccinations, these immunizations, the flip side of this would be a much different world when it came to mumps, rubella, pertussis, polio, measles, chickenpox. I mean, there'd be a lot of sick people, and some of these are poor outcomes. They're very poor outcomes, or they could be debilitating long term. And so these are things that we want to prevent. And so it's important when we start looking at profiles of immunizations. Now, you can't make anybody, make or mandate people to get vaccines. However, there are certain professions that require hiring, employment based on your immunization history. So as a provider or a healthcare worker or frontline person, you need to have the very minimum of immunizations. And that also includes hepatitis B, because you're dealing with sick people. You're dealing with, and you could be the arbiter of transmission if you're not a vaccinated person. So it's important that frontline professional people are immunized, that have the immunity, that have been appropriately vaccinated, because you don't want to be the focal point of transmission for a disease that could have been prevented. So providers, essential workers, these are those high priority frontline individuals in the health field that will need to get vaccinated, without a doubt. So does that help?
It does a little bit. I mean, it does clear the picture, because we do get people that say, I'm going to do it or I'm not. And then they're saying, well, the government orders it, I don't trust the government. And what you're saying is there's professions that require it.
Yep.
And on top of that, there's going to be layers of that religious orders can say what they're going to cover and what they're not. And we're not far enough down the road to see exactly what that's going to mean and what it looks like. But for sure that there are professions that you need to have these kinds of things, and they are clearly spelled out. Jeremiah, you're out there and listening and watching. We got a couple comments and our time is running quickly out. I'm hoping that, I don't want you to put these two questions together. They're very important. So if you could take a look at and go through one at a time, and we will make sure that we cover these answers before we close today. Jeremiah?
Yeah, thank you, Mark. This is actually a person who I think tuned in last week, and we answered a few of his questions, but he seems to have had COVID, has had it for 2+ weeks, has been over it and tested negative for 4+ weeks, but has still been experiencing loss of taste, fatigued, equilibrium is off, and memory is bad, has some trembling in arms. Just a question of how long do these effects or after effects last? Should they be tested again? Just what your thoughts were on that.
Yeah, so I mean, we're finding scientists and papers and research, they're finding more and more of the impact of this virus. And what they're finding out is more, the virus impacts organs. The impact is directly to organs. So, we're talking about direct impact to the kidneys, to the pancreas, heart, lungs, of course, and even brain, the brain. And so what's coming out as a result, because we really didn't know what the impact was going to be on this virus from a physical standpoint. We knew people would get sick, without a doubt. But now we're seeing these lingering symptoms, and just like you mentioned, this individual has negative tests, but the impact of the virus has taken a physical effect, and we're seeing what that may be. There are olfactory nerves that may have been destroyed as a result of the virus. Olfactory nerves, these are the ones that allow you to smell. In terms of fatigue or from a neuro standpoint, from a brain standpoint, there could have been an impact in that regard. And impact, I mean, I don't want to, without, people have been known or has been shown to have strokes or TIAs, young people, old people, middle-aged people. And so what we may be looking at are the side effects of what the virus can do to the body. And I think perhaps in this individual, we may be seeing the impact. This person may be seeing the impact of the result of the infection on particular organs. So what we don't know is how long this lasts. Nobody knows. We don't know if, we do know the vast majority of people will, who get the virus, recover from the virus and go on to be just fine. But we're also seeing these subsets of individuals who have, and we've seen this in the news, they come up with this Kawasaki's like syndrome, or we see people that come in with, young people that come in with strokes, and we're hearing about the impact on the blood vessel and the ability to form clots that cause clotting problems. We're seeing that the direct impacts of the virus on organ systems. So people who have diabetes, the impact is directly on the pancreas and rips right through it and causes people the inability to regulate their sugars, which requires, more intensive treatment. And so we're finding more and more as time has gone by. We don't know how long this individual will be affected by this. It could be months. Who knows? Maybe a full year before someone recovers or shows full recovery. At least in the general sense of feeling like back to their normal self. It could take months, and we just don't know the answer. And that's the unfortunate thing right now. There's not enough data points or information or individuals like this person to kind of look and follow. This person will definitely be one that will be followed over time to find out, people who've lost their sense of smell or taste, how long does that take? We may find out it may take 6 months. 12 months. We just don't know.
Thank you, Dr. Ignace. We had another question too, and I know we've been dealing with this as a clinic. I know a lot of the other FQHCs who we've been on talks with have been dealing with the same thing, and that's of patients kind of delaying their care for preventative care because they're either afraid to come to the clinic or, you know, for fears of exposure or what have you. Are you personally, and I guess us as a clinic, seeing those kind of trends?
It's not a trend. It's happening. You know, individuals are delaying care, treatments. I wouldn't say for, you know, more of the chronic items, such as, you know, individuals who have diabetes. Obviously, they need to be assessed. They need to have their medications. They need to have adjustments if it's uncontrolled. But when we talk about individuals who, let's say, just have high blood pressure, they may or may not be on medication, and maybe they're being followed and tracked over time. They're just not calling in, or they're not getting a visit, either by telehealth or face-to-face, and they forgo their medications, or they don't get their refills for whatever they're being treated for. Short term, some things can be, it's okay, but the long-term effect could be impactful. And I'm not talking about next week, next month impactful. I'm talking about a year, 2 years, 5 years from now. Uncontrolled or untreated problems can have a longer lasting effect. That's for chronic care management. When we talk about the prevention of diseases such as cancers, so we're talking about routine mammograms, cervical, colorectal cancer screenings, prostate. So, you know, these are preventable, and early detection is the key in prevention. And so, yeah, there are delays. Every hospital stopped, essentially like mid-March, they stopped doing routine screenings. We stopped doing elective procedures. Elective procedures would be a colonoscopy. We stopped doing all of these elective procedures for a very long time. And just recently, maybe in the last 4 or 6 weeks, we opened, hospitals started to bring back elective procedures and started doing, you know, preventive health screenings, cancer screenings. So you can imagine, you know, 3-month, 4-month, or 6-month delay in getting individuals into that is going to have an impact. Without a doubt, it's going to have an impact. So for a period of time, you know, historically there is a diagnosis or a indication of, or at least a screening process for cancer. We were diagnosing cancer pretty regularly every day or in every month. Well, since March to even up to the beginning of June, there was hardly any of that going on. And so there's going to be an impact, and there's going to need to be some catching up to get people who are supposed to, who would have maybe have been identified early, now are pushed back 6 months or maybe even a year before they actually get their preventive screen. So there's going to be an impact. And again, we're not going to see it immediate. We're going to see it in a year from now. We're really going to get the impact of everything that happened this spring. The long-term impact is going to come. We just don't know those numbers yet, but it's coming. It's coming.
We're running long here, Dr. Ignace, and which is fine. I mean, I think you knew that was good coming when you were going to talk about this. But the final question here that's been written out is, will immunization cause damage to organs? I mean, if we are being injected with virus antibodies, will we experience some of those side effects, meaning damage to internal organs? Is that direct question? So just kind of, if you might speak to that, and we'll go to a final question.
So just a point of clarification. So when we get vaccines, my sense will be that we'll be getting the antigen, or um, basically we'll be given what mimics or looks like the virus, so our body will respond. Our body will respond in a way that mounts antibodies. Our bodies will develop the antibodies as a result of the vaccine. So that's kind of, so we're not getting injected with antibodies. We're getting injected of the antigen, or the properties, or the protein properties that look like COVID virus. And then our body we're not injecting live virus in you to get infected. That won't be the case. These are genetically modified replicas of the virus. So you won't get the infection, but your body will develop antibodies in that response. So that's kind of the first part to this. Now, the safety profile, that is why these phases go into place. This phase 3, when we look at a large group of individuals, 30,000, profile age, demographics, gender, and you test people. You just don't give them and say, okay, we're only going to test antibodies. No, we're going to be testing your kidney function, your liver function, your electrolytes, your cholesterol. We're going to be doing, routine health checks on you to see how you're doing. So, they will be volunteer to be part of this trial, and they're going to follow these people over time, not just on signs and symptoms, but also look at blood work, look at organ function, look at everything that comes with managing, any introduction of even a blood pressure or some medication. You want to follow and manage these people as time goes by. So, my sense, if there is a sense of organ injury or involvement, they're going to know that up front. And if that's the case, it will never come to market.
So the last question is kind of related. This is a native to native conversation. So that's where this is coming from. 3 days ago, the Washington football team, part of the NFL, decided to change its name. And in a lot of communities, Milwaukee specific, the community, the metro community politically has taken the stance that racism is a matter of public health. Native people kind of seeing this in the last 3 days and seeing the name change, there's lots of people being fired up on social media. And they're saying now's the time to go to the school board meetings, to get those schools that want to change their name, that need to change their names, to change the name. And they want to flood those meetings because, well, of course, they're encouraged by what happened at a professional ball club level. So I'm kind of watching this traffic go back and forth, and I think about our conversation. So kind of here's the concern that I see in this personally, and I've been a part of it pre-COVID, meaning there's a school board meeting. They take public comments. The rooms are sometimes 30 by 40 or 60. And you get this crush of people on both sides of the issue on race-based mascots and logos in public school, private school sports. So they're walking into this building. Folks are knowing each other. They're coming from different places. And of course, well-meaning. But let's say you're one of those folks out there that's going to make that stand for social justice now, and you're going to be walking into that room. What would you tell them before they walk into that room? What is it that they're wearing? What is it they're doing going in? And what is it they need to do coming out of that room?
I figured there was going to be a COVID question there at the end. So wear a mask. And so it's wearing a mask. Keep 6 feet distance. Bring your own hand sanitizer too. And what I'm finding or hearing and reading more about over the last couple of weeks is that not all masks are the same, just like all face coverings are not the same. So if you're going to go into a public setting, if you're going into a public setting where you know there's going to be individuals, I would look at getting a surgical face mask. What we're finding out, or at least what some articles and publications that are coming out, is that face coverings are just not effective. The cloth coverings just not effective. Mark, if that's made of cloth or cotton, I guess that's better than nothing, but at the same time, a surgical mask is 10 times more effective than a cloth mask. So if that's the case, and you feel so inclined to partake in such forums, that you look for a surgical mask, and that would be the best protection that you could. But even face masks aren't absolute. The only thing absolute would be a hazmat suit, and none of us can afford that kind of stuff. So, but if you can find face mask, surgical face mask, do it. If it's just a face covering, cotton product, it's not very effective. It really isn't. So
Then maybe we can say, maybe make your public comments in written form and turn them in and have someone walk them in.
Well, if you have it on a Zoom like this,
Sure.
I mean, we could have those more vocal discussions and be socially
right.
distant at the same time.
Well, it is a native to native format. So Dr. Ignas, thank you for your time. This is one of our first shows since the very beginning. The first one we ran over just a little bit, but we've run over and we've talked about a lot of important things, new information. Thank you to everyone that's joined us. And as is customary, we turn this over to Dr. Ignas for some final thoughts and words. And please stay tuned for next week. Certainly there will be far more coming in the news, and we need to digest it in a responsible way. So thank you for coming in, to those of you that are here, and please talk about this to those who are unable to tune in, so they are in the know with some of the latest information in our Native community. Thank you. Dr. Ignas?
Thanks, Mark. Thanks, Jeremiah. And I'm trying to bring the most latest information to this audience, and I know people tune out and tune out to the headline news. They just don't want to get into whatever discussion points that they want to talk about. But I wanted to cut through that and get straight to what is really on the forefront. And from a science base, these biotech companies, I'm very optimistic. I'm cautiously optimistic, but these are very promising headlines that are coming out, and they don't get much play, but I want to get it to natives, and so they have a better understanding of what's coming. And so it's important. I know we went over, these aren't easy discussion points to have because they get technical, but at the same time, I want to make sure that people are aware. Vaccines are coming, and these discussions are going to be coming, and it's going to be important to understand what your health system is going to be able to do for you. And so the more information I get, the more I understand and seeing how this is all going to play out. You guys are going to hear this. And so I'm trying to be straightforward. And so with that, what I'd like to do is say goodbye and keep yourself safe. A lot of places are mandating masks. just wear a mask. It's really to help protect you, your family, and your aunts and uncles, and all of your relatives. And so until next time, everyone stay healthy and stay Native strong.